online for folks. I'll go over that in just a minute. So let me get my slide here. There we go. So this is all offered through the ATTC network, which is made up of 10 regional centers. You can see all over the map here. And we're all funded by SAMHSA. Very cool organization. So our team specifically is the Northwest ATTC, and we serve Alaska, Idaho, Oregon, and Washington. And what's just so great about the whole intent of the ATTC is it's all about free education and consultation to everyone across the United States, and it's all aimed at strengthening the addiction workforce. So very exciting initiative and amazing resource. So here we go. I don't know, Mandy, if you're able to put this in the chat for me right now, just that little link there, but you can also do the QR code there, and I'll put it in the chat in just a minute when I'm not sharing slides. This is just a very quick pre-survey. We sent it out to you. If you haven't already filled it out, you can just take 2 minutes to do that right now while I'm going over logistics. We love our data. So a few little logistics. We will be recording during this presentation. And part of this is we really want to make this accessible to everyone if they're not able to be here. We will not be recording the piece at after the presentation where we have time for questions and discussion. It's just going to be the presentation piece and feature Bill in that piece and in the slideshow. So just a heads up about that. The format we're going to do this so that we have a nice flow and have plenty of time for the whole presentation is if you have questions, throw them in the chat. I'll keep track of those, and we will have plenty of time for Bill to answer those questions after his full presentation. In addition to time for discussion where you can unmute and ask questions as well. That is the basics with the logistics there. And I don't know if he really needs an introduction. Everybody knows him pretty darn well. Amazing presenter today. So I am honored to introduce Dr. William R. Miller, Emeritus Distinguished Professor of Psychology and Psychiatry at the University of New Mexico and co-founder of Motivational Interviewing. More than 50 years of experience, dozens of books, still working on books. We were just talking about one that he's working on. And Dr. Miller's work really has shaped how we understand addiction, behavior change, and the spirit of compassionate care. So please welcome me in welcoming Dr. Miller. Thanks so much for being here today. I am going to stop sharing my slides and let you share now. Thanks so much, Bill. It's really great to see you.
Likewise. Thank you, Lindsay. And there we go. Okay. See if this is working. Yes, it is. Good. Okay. Well, basically, I want to tell you a story of how motivational interviewing got started and how it's evolved amazingly over the years. And take about an hour, probably a little less to do that. And then we'll have about a half an hour for discussion or questions or whatever after that. My graduate training started at the University of Oregon in Eugene, and something that happened there was important in the eventual emergence of motivational interviewing. Oregon was a very behavioral program, and if you're going to graduate from there, you were expected to be a behavior therapist. And before any of us set foot in behavior therapy, we were all required to have a year-long course in how to talk with patients, basically on a person-centered approach. And they went across campus to find a faculty member to teach that from the counseling psychology program. And her name was Susan Gilmore. She was a student of Leona Tyler, who was a student of Carl Rogers. So we had the good fortune of having an academic grandchild of Carl Rogers teaching us a person-centered approach. And soon after that, I went on an internship after my second year of training to Milwaukee, Wisconsin, to the Veterans Hospital there. And basically, the only clinical training I'd had was that year course in how to listen to people. And the director of training said, well, we have a lot of treatment units here. Why don't you just kind of do a pilgrimage around them and see where you would like to spend the summer? So that's what I did. And a number of the units I had had some experience in doing the kind of thing that they were doing. But there was a unit treating alcoholism. And so I stopped in there. It was directed by a psychologist named Bob Hall. And Bob said, what do you know about alcoholism? And I said, well, nothing really. He said, any lived experience or family history? He said, no. That's well, what do you remember from your graduate courses? And I said, well, I don't remember it actually coming up. And Bob said, well, then this is the first or second most common diagnosis you're likely to encounter in your lifetime. You might want to learn about it. So I spent the summer with him, learning, but also talking to patients. And all I knew how to do was listen. So that's what I did. And I really enjoyed the conversations, and the patients seemed to enjoy the conversations too. And by the way, I then began reading about alcoholism in the professional literature. And it said alcoholics are pathological liars and in denial and very difficult patients and have all these robust defense mechanisms. And that doesn't sound like the people I was talking to, but maybe they're different in Milwaukee. I don't know. But I got interested anyhow, and eventually decided to do my dissertation in the area of alcohol problems. And so that was an important start for me. I joined the faculty here at the University of New Mexico in 1976 and began doing studies of behavioral treatment of alcohol problems. And in doing those, we had manual guided therapies that was expected at the time. If you're going to get funded, you had to have a manual for what you're doing and specify the procedures. And in this particular study, we did a whole series of 7 of them, actually. But in this clinical trial, we randomly assigned people to either 6 outpatient sessions of behavioral self-control training or 18 sessions, which included the 6 sessions, plus behavioral things focusing on other issues that are often related to alcohol problems. And people could choose among those. So we call that broad spectrum behavior therapy. Or self-help. The people in this condition, we simply met with them once, gave them our self-help book, which was called How to Control Your Drinking, and said, we'll see you in 10 weeks. And I was concerned that in these studies, people would be disappointed or upset that they didn't get to see a therapist right away. And some were, but for the most part, people said, oh, you mean I can do this on my own? Oh, that's great. And went home. And so the question was, what would happen in this study? This is my staff. Back in the old days, you can see how old the days are. We went down to Old Town Albuquerque and had our picture taken. And there were 2 supervisors besides myself, and they were seated beside me on either side. And then we had 9 therapists, all doing the same behavioral approach, manual guided, as a way of trying to help people who were presenting themselves to the clinic with alcohol problems. We didn't get what we expected, which has been true of my research in general. There were no differences in outcomes among those 3 conditions. Among self-help with 1 session or 18 sessions of behavior therapy, the outcomes were the same, and the outcomes were good. And the only thing that predicted client outcomes was the therapist who treated them. Our variations in how much behavior therapy and the content and so forth didn't seem to matter that much. But outcomes did vary according to who the therapist was. And specifically, we were at this point measuring accurate empathy using a tool developed by Truex and Kharkov, who were two of Carl Rogers' students, to rate therapist level of accurate empathy. And so we independently rated the 9 therapists. We agreed very highly about how empathic their skills were. And basically, the better therapists listened, the less their clients were drinking 6, 12, and 24 months later. We lined up those 9 therapists according to their skill and empathy. Number 1 therapist, the most empathic, and all of us rated her as number 1. And number 9, the least empathic therapist, and 2 of us rated that person 9 and the other one 8 out of 9. And here are the percentages of their patients who had good outcomes, who made significant changes in their drinking. We also had a group, as I told you, that went home with a self-help manual, and their success rate was 60%. Now, if you average all the therapists together, their average success is 61%, which could lead you to conclude that therapists are no different from self-help. But look at the graph. There are 5 therapists here who are getting somewhat better results than people working on their own. There's 1 therapist, number 7, who had just exactly the same rate of positive outcomes. And then we had 3 therapists who it looks like clients would have been better off going home with a good book. And that was an unexpected finding, but striking. Well, with that, I went off on sabbatical leave to Norway, to the clinic at Yellestad, which was an alcoholism hospital. And they had engaged me to come and lecture about behavioral treatment of alcohol problems. And so that was what I was doing in the gymnasium for the staff. But the director also said, would you be willing to meet personally with the therapists? They're interested in talking with you. And I said, sure, I can do that. And there were, a social worker and a chaplain and mostly psychologists, most of them pretty young, recently out of training. And so I was working with them, teaching them behavioral strategy and also teaching them a person-centered approach, essentially Carl Rogers, how to listen with active listening skills, with reflective listening skills. And they didn't want to just have me talk to them. They wanted me to show them what it looks like. So I said, well, okay, how will we do that? And one of them, who was particularly facile in English, said, well, I'll tell you what, I will role play clients that we're seeing that we're finding difficult and just show us how you would respond. And you might suspect that the underlying unspoken dynamic was, okay, smart guy, how are you going to deal with this? It was fun. We did that. And another unexpected thing was I would be demonstrating for about 2 minutes and they would stop me. They would interrupt. And my American students seldom did that, but these students were very reflective, almost philosophically trained. I wanted to know what's going on inside my head. So they would stop and literally say, but what are you thinking right now? Tell me what's going on right now. Or they would ask specific questions. You're teaching us how to do reflective listening. Good. I can see that you're doing that. But how do you know what to reflect? Of all the things that the client is saying, you reflected something in particular the client said. Why did you choose that? Because the client said many things. Why are you reflecting that? You asked the client a question. Okay. Why that question? Why not some other question? What's guiding your thinking about what to ask and what to reflect? And so they caused me to verbalize some decision rules that I seemed to be using, of which I was not aware. And we began assembling them and started writing them down. And one of the concepts was it should be the person rather than me who's voicing the arguments for change. So I was arranging the conversation so that it would be the clients who are telling me what they would like to change and how they would do it and why that's important and so forth, rather than my advocating for change. Addiction treatment in the US at that time was highly authoritarian, highly confrontational. Sit down, shut up, you don't know anything. I'm going to tell you what's wrong with you, and here's what you need to do. Just the opposite of Carl Rogers, really. So what I was doing was unlike American treatment, but very like the listening that I had been taught by Susan and others. I was very interested in understanding the client's own concerns and their own motivations. So I would be asking questions about those. I was certainly listening with accurate empathy, this quality that Carl Rogers described, in which you reflect back to the client your understanding of what they mean, and then they have a chance to say more or correct it, say, no, it's not that exactly, and they tell you more. So together, you and the client are discovering more clearly what the client's experiencing. And then when I would meet what at the time was called resistance of clients maybe minimizing the problem, or I don't really have a drinking problem or whatever. The way I would respond to that, I never pushed back against it. I never disagreed with it or argued with it, because doing that actually strengthens it. And instead, I was mainly listening and trying to understand what the person was saying. So a very different way of dealing with what therapists were calling resistance at the time, certainly very different from what was being done in addiction treatment. And then also nurturing hope and optimism, because if you cause a client to perceive that there's a serious problem, but they don't think there's anything they can do about it, you haven't done them any favors. Then they're just miserable. So it's a combination of helping them to look in the mirror and see what's happening, but then also see that there's hope, see that there's something they can do about it. So that seemed to be the nexus of what I was doing in these conversations. I wrote down a paper because Carl Rogers said, when you have a different idea, when you have a new idea, write it up and send it around to some colleagues. He called it a discussion paper, and just get their opinions on it. So when I wrote the paper, I called it Motivational Interviewing. And I was thinking of it at the time as just a preparation for treatment. So this might be something you would do early to kind of prime the pump or get people ready to do therapy in a way. So I did write such a paper. I sent it to several colleagues, saying, what do you think? Sent it to Alan Marlatt, sent it to Ray Hodgson, a psychologist colleague in Wales, Cardiff, Wales. And I got some comments back. And one from Ray surprised me. He said, I want to publish it. I want to publish it in this journal that I edit called Behavioral Psychotherapy. I said, Ray, we just made it up. I mean, I don't have any data at all. The only numbers are the page numbers, for goodness sakes. And he said, no, really, I think it's a good paper. Let me publish it. So I said, okay. And he said, cut it in half, which editors always do. So I did that too. And among the people he sent it to, unbeknownst to me, was a young colleague named Steve Rolnick, who reviewed the paper. I wouldn't meet Steve for another 7 years. And so that was published in the journal Behavioral Psychotherapy, and that is the first published description of this approach to helping people with alcohol problems. It had resonance with something else that was growing up in the early 1980s, late 70s, early 80s, which is the Prochaska and DiClemente model that's now very well known, called the trans-theoretical model of change, saying that change is not something that just happens suddenly, but it emerges in steps. In the beginning, you're not even thinking about it, that you don't see any problem or you don't see any hope. And that's what they called pre-contemplation, not even considering it. Then you begin thinking about it. Maybe I should do something about this. I don't know. Maybe I'm drinking too much. I don't think I am, but yeah, well, I might be. And that's ambivalence, right? That's both seeing a problem and not seeing a problem at the same time. It's wanting to change and not wanting to change simultaneously. And I discovered in practice that actually that's where most people come in. Then as ambivalence evolves and the balance begins to tip a little bit in the direction of maybe I should change, then people start thinking about, well, what could I do? And that's the preparation stage. Is there something I could do about this that's acceptable to me and possible for me? And if they find something that, and this is us, this is human beings, if we find something that looks like, I think I could do that, you might try it out. That's the action stage. And if you do succeed in making the change, then you're in the maintenance stage of sustaining the change that you kept. Smoking was where Prochaska and DiClemente started. So people sometimes aren't even thinking about quitting smoking. Then they can sort of ambivalent about it. Then they begin to think, well, what could I do? Maybe I could, there are these patches or, whatever. And they try something and they quit smoking. And the challenge is staying there because people go around this wheel, smokers go around this wheel between 3 and 7 times on average before they finally quit. And so that model made a lot of sense to me. And motivational interviewing seemed to fit with it because when I was trained as a behavior therapist, I was trained what to do when people are in the action stage, but not much about what to do if people aren't there yet, which is where most clients are, I find. So motivational interviewing was something you could do earlier when people seem to be in contemplation, even pre-contemplation or preparation to help them get ready for change. And that's why I was thinking of it as a preparation for treatment. So I knew Carlo DiClemente already, and we corresponded and began working together. Came back to New Mexico after Norway and thought, well, okay, interesting ideas. How could we turn this into a treatment? How could we actually try this? What would it look like? And so I developed something called the drinker's checkup. We meant to attract people at very early stages and offer them an evaluation of their drinking and its effects and give them one session of feedback and treatment referral information. So we advertise this in the papers that we have a free checkup available for people who, if you wonder whether you're drinking too much, just come in and get a checkup. And a lot of people responded to that ad. Most of them had never been to any kind of treatment, weren't considering going to a treatment, but a checkup, they would do that, and so that's what we did, and we responded in an empathic kind of way as we gave them their feedback. Unexpected results. We gave them a list of treatment programs. Almost nobody went to treatment. They went ahead and changed their drinking on their own. On average, cut it in half. Substantial reduction in their alcohol use. That was sort of a surprise. And that, by the way, eventually became what I'll tell you about in Project Match. It came to be called motivational enhancement therapy, which is a combination of motivational interviewing as a clinical style and giving people personal feedback about their assessment results. In another study, we compared 2 different counseling styles for giving feedback. So when you say to somebody, you're drinking at the 95th percentile, so you drink more than 95% of the population, and you got 4 or 5 buddies out of 100, Sometimes people say, that can't be right, and they want to say that I don't really drink that much. How do you respond? American addiction counseling style would be to say, well, no, wait a minute. We added up your drinking, your number of drinks per week, and it was your own report, and here it is. Does that look about right? and here are the drinking norms, and you're at the 95th percentile. Or do you respond in an empathic style and say, so this doesn't make sense to you. This surprises you. Not what you expected. So we had the same counselors do both styles. And I will tell you, some counselors were way better at one than the other. All right. What we found was both groups reduced their drinking, and we had a waiting list control group. That's the orange line. They seemed to be about where they were to begin with. Then we gave them the checkup. Their drinking went down. Got a little splashback, which we found in several studies. If you put people on a waiting list, they don't respond as well to treatment as if you see them right away. Interesting. It doesn't last as well. And we noticed that our clients behaved differently in these two conditions. In the directive condition, the green bars are how much is the client making the arguments for change. We now call that change talk. Right? What you see is in the empathic responding condition, we're getting twice as much change talk as in the more directive or confrontational responding. And when we look at the opposite, the client arguing against change, again, you get half as much of that and when you're empathic than when you're being more directive. And we later learned that that ratio of clients' change talk to sustained talk is a pretty good predictor of whether they're going to change or not. So if you look at the directive side, it's just 50-50. It's an operational definition of ambivalence, basically. Equal amounts of arguments coming from the client in favor of and against making a change. In the empathic responding condition, very different, about 3-to-1. And we also noticed that one counselor behavior predicted client outcomes substantially, 0.65, triple 001. And what was that? It was confronting. The more the counselor confronts, the more the client drinks. It was a direct relationship. Well, that's interesting. Then I went on a second sabbatical to Sydney, Australia, to the National Drug and Alcohol Research Center. And in the office next to me was a guy named Steve Rolnick, whom I had not met before. And Steve said, Millie, did you write a paper about motivational interviewing? I said, oh, you read it? I'm grateful because there wasn't much interest in it at that point. And Steve said, not only did I read it, I'm trying to teach this in the United Kingdom where he lived. He lived in Wales. And it's become a very popular approach for treating addictions. And I don't even know if I'm doing it right. You got to write more. And so I said, well, show me what you're doing. And he really understood and could do what I was writing about. And so I said, let's write together. And that's where the first edition of Motivational Interviewing came from in 1991. It was only about addictions, central role of ambivalence, that people both want and don't want the drugs that they're using. We defined 5 principles of motivational interviewing. And about that same year, as a matter of fact, I had to fly back from Australia for meetings of this research group. Project Match began. This was an 8-year study funded by the Alcohol Institute. It cost $27 million in the end. We treated 1,726 clients for alcohol use disorders. And once we were accepted to be a principal investigator in the study, we threw away our proposal and started over to design the study. And we knew we could test 3 treatments. We had statistical power to compare 3 different treatments. What are they going to be? Well, one of them was pretty clearly going to be cognitive behavior therapy because that's what all the investigators at the table did. Then there was this 12-step stuff that's happening all over the world, really, but especially around the United States. And it's really popular. And so maybe we can design a treatment around that. And so we got people who were expert in that to design a 12-step psychotherapy to help people understand and get involved in and work the early steps of the 12-step program and get engaged in the 12-step fellowships. And then, okay, we got two. Now what? What's a third evidence-based approach? Because we want treatments that are really different in their conceptual background. And behavior therapy and 12 steps were almost at opposite ends of the world in terms of how you think about things. Well, motivational interviewing, I talked about it, and they said, well, that'd be a good third alternative because it's not really like the other two. And how long does it take? I said, well, normally 1 or 2 sessions. I said, oh, well, look, those are getting 12 sessions. We can't have a 1-session therapy here. I mean, can you stretch it some? Can you make it longer? And that's where I said, well, we can give some assessment feedback, and we can do a couple of follow-up sessions. I said, okay, so we developed a 4-session motivational enhancement therapy. That was the third treatment to be tested. Everybody was followed up to 15 months. And the purpose of the study wasn't really a horse race. It wasn't really to say which of these is the best, although all of us were kind of rooting for one or the other, but rather to predict who does best in each. And so we did our best to come up with predictions of who would do best in cognitive behavior therapy, who would do best in 12 steps, who would do best in motivational enhancement therapy. I can give you the bottom line on that, which is we were terrible at predicting who would do best in which approach. But the comparison of treatments was interesting because here it is. Over follow-up, the lines are right on top of each other, and they're good. They're going from 30% days abstinent up to about 80% days abstinent, a little better than that. Over time, and all 3 groups sustain it well over time, even out to 3 years. We did a longer follow-up. So we got 3 treatments that we thought were really, really different from each other that, in fact, yielded the same outcomes. That was a lesson in humility. And then we began to test our match hypotheses, and there was another lesson in humility. There were a few that worked, but actually more of our hypotheses came out in the opposite direction than the one that we predicted. So bottom line, clinicians are not very good at deciding which approach is going to be good for clients. Well, Steve and I began then teaching people how to do motivational interviewing because we thought maybe the 2 of us won't be able to keep up with the demand for training in this approach. Little did we know. So we began training people in 1993, 2 years after the book appeared. We noticed something early that I'll talk about in a bit that has to do with spirit of motivational interviewing. But as we were doing these annual trainings, after a few years, people that had been trained said, could we get back together and compare notes with each other and talk about training experiences? And Steve and I said, well, you can come and meet the same time we do and have a little group. And that was the beginning of the MI network of trainers, which eventually incorporated and now has trained something over 4,500 trainers who speak at least 61 different languages. Something Steve and I noticed when we were training clinicians was that they were doing what we taught them to, and we were horrified. They had the words, but not the music. It felt wrong. And they were kind of using the techniques, but it was like they were using the techniques on people to trick them into changing. And of course, you see that a mile away. I mean, you can feel it. And that wasn't their fault. But Steve and I said, what did we leave out? And it was the underlying spirit, the mindset or the heart set with which you practice these techniques. And we now describe that as having these components. It's a partnership. We're in this together. It's not an expert fixing somebody. And we're having a conversation about somebody's life, and we're kind of walking on the journey with them. And we both have expertise. I have professional expertise, but each client has tremendous expertise about their own life. And acceptance of people as they are, non-judgmental, and compassion, benevolent intentions, your genuine desire to help. And the important person in the room is the client, is what they care about, what they want in their lives. And then empowerment, related to the early idea of hope, that it doesn't mean giving people something they didn't have. What we mean by empowerment is helping clients to see and use what they already have and empower them to do so. So when we began including that in training, then it started looking like we wanted it to. So those four components now make up the spirit of motivational interviewing, which is important. In Oregon, my next sabbatical, went to Portland and I worked at Kaiser Permanente. And I got a call from a probation office saying, we hear you're in town and you're on sabbatical. Would you come down and teach us motivational interviewing? I said, well, look, I'm on sabbatical. But I'll tell you what, if we can make a study out of it, I'll do it for free. But here's what I need. I want you to get audio tape samples of your probation officers practicing, working with their clients before, and then again after treatment or training, and then again a few months later. So we can take a look at how practice changes. And I was talking to the director of the office. So he said, yeah, we can do that. And you didn't get into training unless you had turned in a tape. So had to get tapes from people. So I wound up training probation officers. 22 people. We got their pre-training samples. They took my 2-day workshop in motivational interviewing. We offered optional follow-up groups for additional skill development. We got a practice sample with a simulated patient right after training. Then I had to develop a coding system. So what are we looking for? And how do we know what's good MI? And we applied that to these tapes. And then 4 months later, we got another set of tapes from the clinicians, from the probation officers. And we did questionnaires also, as you do when you do a training, And I got rave reviews, wonderful training, one of the best trainings I ever took. This is so useful. I'm using this every day in my practice. One thing I noticed went down is desire to learn more about motivational interviewing. It decreased. So when I went back and talked to them, I said, tell me about that. Well, we already learned it, they said. So yeah, it'd be interesting to learn more, but we got it. However, then I listened to the tapes and there was very little evidence that I had been there. No significant increase on acceptance, empathy, warmth, spirit. On MI consistent responses, got one more reflection per 10 minutes of counseling. Is not enough to make a difference to clients. Statistically, it's an increase, but it wasn't much. Short-term increase in that, and in 4 months, pretty much going back to baseline before. And we listen also to what the clients are saying, and there's no increase in change talk. So it doesn't seem to be influencing the clients. Also, we noticed we didn't decrease MI inconsistent responses. So they're still kind of confronting and directing and being authoritarian. And the ratio of client change talk to sustained talk didn't change. And we know now that's a good predictor. But I gave them confidence that they were now doing motivational interviewing. So I created false confidence. Well, that's interesting. What do you do with that? What it did was suggest another line of research that's been going on ever since that I'll tell you about in a bit. But I went off to Italy with Steve, and we wrote the second edition of Motivational Interviewing that now isn't just about addictions. It is now spread into healthcare and corrections and other kinds of fields. So it's not just about alcohol and drugs anymore. So more broadly about behavior change. We've now included the underlying spirit because we learned the hard way how important that was. We got rid of shot one of the 5 principles because it was asked, now how is avoid argument different from role of resistance? And I said, well, I'm not sure. So we got rid of avoid argument. We introduced ORs, open questions, affirmations, reflections, summaries. as client-centered behaviors that are fundamental, and started describing this as a way of being with people. We also now introduced the idea of change talk. Previously, we'd been talking about self-motivational statements, things that clients say that seem to move them toward change. So we just give that a different label. And that the counselor influences this. And the opposite of change talk we call resistance. And that's interpersonal behavior, again, influenced by the counselor, that suggests, I'm not going to change. And then 2 years after we published that, I met Paul Amrine. Unfortunately, just a little bit late. Paul is a psycholinguist and came to us, did his colloquium on how people reach agreements, how people negotiate with each other, and how you make requests of somebody. And so I sat down with Paul after we hired him, and he said, this idea of change talk honestly is kind of messy from a psycholinguistic perspective, because you're mixing together things that sound very different to my ear as a linguist. I said, well, teach me about that. So he said, well, there's desire language, people saying, I want, I wish, I would like, I would prefer. Every language on the face of the earth has that. And then there's ability language. I could, I can, I'm able to. Reasons, it would be good if I did this because, it'd be bad if I don't do this because, needs statements that have urgency. I've got to do something about my smoking or drinking, whatever. And then there's commitment, which is I'm going to do something about it. So he was teaching us these different categories of language, which we then gave the acronym DARN to: desirability, reasons, need. And as we started looking at commitment, we found some things that were related to it. Activation language is not quite committing. I'd be willing to. I'll consider it. Those aren't things you say when you go to the altar to get married. They're not commitments, but they're getting there, And then we also noticed people would come back to a subsequent session and tell you something they had done that moved in the direction of change. So we call that taking steps. And so that's where CATS came from: commitment, activation, taking steps, listening for and trying to encourage that particular kind of talk. The opposite type we called sustained talk, just the opposite side of ambivalence. So what does it take to learn MI? That's the question that came out of my study of my humiliating study of my own training. And so we did a randomized clinical trial with 140 clinicians from around the country, and we randomly assigned them to just get our workshop, or get a workshop plus some feedback, or get a workshop plus some coaching that we did on the telephone, or a workshop plus feedback plus coaching, the whole enchilada, or to read the book and watch some videotapes. So I said, how do people do at learning this? Well, read the book, watch the videos, no change in practice behavior. Come to a 2-day workshop, same thing we found before, little bit of change, pretty short-lived, and no change in how clients respond. Add either feedback or coaching, and you get an increase in MI consistent behavior and a decrease in MI inconsistent behavior. So that's good. But add feedback and coaching, that happens, plus clients begin giving you more change talk. So it looks like the combination of initial training plus feedback plus coaching, and not a lot. This was like on average 5 sessions of half-hour phone conversation, enough to really improve acquisition and to improve maintenance over time. Steve came to New Mexico. We began writing the 3rd edition. What changed? It's now broader than just behavior change. We began looking at things like forgiveness, where you may not have any behavior related to it. You may be forgiving someone who's already dead. And yet we know it's a clinically significant phenomenon. We also understood it's not just about getting ready for change. It's actually a way of working with people as they make the changes. We added what we learned from Paul Amrine about change talk. So now we have Darn Cats in the 3rd edition. And we changed from principles to processes of motivational interviewing. And so that's where engaging, focusing, evoking, planning came from. As 4 four things that you're doing, four steps, if you will, but they aren't exactly linear, but knowing where you are is important. So that was where we began writing about that. We stopped talking about motivational interviewing as directive and describing it as directional. There's a direction to it, you know where you're going, and you're reflecting and asking questions to try to help people move in that direction. We added, how do you respond to change talk? That was a new idea here. So not just what do you do to invite change talk, but what do you say next? And what you say next really matters. We realized that once you know how to kind of tip people's balance in one direction, you also know how not to do it. And so it taught us something about how to be neutral if you decide you really want to remain neutral. And we deconstruct this idea of resistance. We said that there's something wrong with that idea, that it's like blaming the client for not getting better. Maybe you think it's their pathology, maybe you think they're just being mean or whatever, but either way, it's kind of attributing to the client the reason why change isn't happening, when we know, in fact, it's interpersonal. And so we deconstructed it, the concept of resistance, what therapists mean by it, into sustained talk and discord. Sustained talk is arguing against change. It's just a normal part of ambivalence, nothing pathological about that. And discord, a little different. It signals that our relationship is not great at the moment. You're stepping on my toes, So I don't want to stop smoking. That's sustained talk. And you can't make me, it is discord. So you respond to them similarly. Well, what's going on with MI all this time? Publications are increasing in a steep curve over time. And by the way, my late colleague Ev Rogers here at New Mexico studied how new ideas get diffused and how technology gets diffused. And there's a curve to it like this, and we seem to be on that curve at the moment. There are now more than 140 books about motivational interviewing, translations in at least 28 languages, more than 2,500 controlled trials of motivational interviewing, resulting in 240 meta-analyses and systematic reviews. So it's just an explosion of research. We know at least 70 languages in which MI is being taught and practiced, and whole nations and states are implementing this. So all kinds of things are happening. And how does MI cross cultures? It's now being adopted and practiced on 6 continents. We did, with Jenny Hedema, we did a meta-analysis of studies, outcome studies. And Jenny found when you do a meta-analysis, one thing you do is see what predicts effect size, what studies get bigger effects. And she found, interestingly, that when the study was treating minority clients, these are US studies, when the clients are minorities, primarily Black and Hispanic, the effect size is bigger. In fact, it's triple the effect size for white clients. I was hoping that we'd get equal effect size. It wouldn't be any less effective with minority clients, but it's working better with minority clients, even though, by the way, most of the practitioners are white. Interesting. Seems to be a good approach for working with people who are really different from yourself. Why? Because clients are experts on themselves. You don't assume you know them, or you know what they need to do, or you know what's happening. You listen to them. And the idea of cultural humility. We used to talk about cultural competence, which means I know how to do my treatment in multiple cultures, a little bit arrogant, that, Cultural humility is knowing what you don't know. Important. And I know that people from a culture are the ones who are going to know best how to do it there. So I did some training for India last year, and I said, I don't know how to do motivational interviewing in India, but you will. When you learn about the method and the things that we've learned, you'll figure out how you can do this. And that's true in different professions, in different countries, in different languages, kind of across the board. There's something that feels universal about motivational interviewing. It gets picked up and practiced without marketing. It's just interesting that It's like practitioners see this and say, oh yeah, I kind of knew that already. Quick summary of outcome research. Small to medium effects on average, but a lot of variability across studies. Almost always more effective than no treatment or just giving people advice, but lots and lots of variability. About 25% of controlled trials, including one that I published, found no effect of motivational interviewing. Fidelity of motivational interviewing seems to matter. So if the fidelity of practice is higher, you are more likely to get effects. Adding MI to other evidence-based treatments seems to improve outcomes. When you compare just MI with a longer treatment, often there's no difference in outcomes. And there are lots and lots of meta-analyses now. We also know that client speech during the session, from what clients say during the session, you can predict outcomes. More change talk predicts better treatment outcome, but not always. More sustained talk predicts poorer treatment outcome, a little more consistently. What really works is the ratio. The comparison of how much change talk versus how much sustained talk you're getting from clients. Now, didn't we already know that motivated clients, the ones who are saying, yeah, I want to change and I'm going to do it, they're the ones that get better? Well, yeah, but we strongly influence the ratio of sustained talk to change talk. Here's a study Terry Moyers did with Lisa Glynn, 9 counselors. And imagine this now, these counselors were told to change their counseling style every 12 minutes between one of two things, between trying to evoke change talk, motivational interviewing, or doing a functional analysis of alcohol. What leads up to it, what are the consequences of drinking, and so forth. A clear behavioral procedure. It's included many behavior therapy approaches. Talking to college students about drinking concerns. So these were people that had some worries about their drinking. They weren't heading into a treatment program, but they wondered. And what we counted was the ratio of change talk to sustained talk. So that's the dependent measure. In the first segment, first 12 minutes of motivational interviewing, you get 62% change talk. Then the counselor switches to functional analysis, which, by the way, the client usually doesn't notice. It doesn't feel like anything's different. But now change talk's only 46%. Then you switch to motivational interviewing, 67% change talk. Then you go back to functional analysis, 54% change talk. Both sustained talk and change talk go up and down in step function based on what the clinician is doing. So it's not just the motivated clients get better. We influence something about their motivation that in turn predicts change. How about training research? Reading and watching videos has basically no effect on practice behavior. And MI training normally yields kind of medium to large short-term skill gains. But they can fade quickly over time. Feedback and coaching help, both with acquisition and maintenance of MI skills. False confidence is common. So there's very low correlation between how well people say they can do motivational interviewing and how well they actually do it. So if you're hiring, don't just ask people, how well do you do motivational interviewing? Have them show you. Same thing with reflective listening. Most people say they are much better listeners than they really are. If you want to know how well somebody listens, have them show you. Lots of variability in how long it takes people to develop proficiency. Pre-training skill and accurate empathy facilitates learning of motivational interviewing. If you're already pretty good at Carl Rogers, you're going to learn this faster than somebody who has to learn that too. And we've never found a relationship between years of education and the ability to learn motivational interviewing. My follow-up line to that is even PhDs can learn it. Stuff can get in the way if you get too much education. I was asked to talk about co-occurring disorders, and so I'll say a bit about that. We used to call it dual diagnosis. It's the norm. If you treat addictions, it's the norm for there to be 2 or 3 or 4 more diagnoses along with it. So this is not unusual at all. Addiction comes with health problems, comes with mental health problems, comes with social functioning problems, comes with financial problems, comes with legal problems, comes with all kinds of things. Meta-analyses indicate that MI with behavioral health issues like anxiety, depression, gambling, tobacco helps. So it's common with the things that are most often the co-occurring disorders. And also tends to improve treatment relevant things like clients staying in treatment or adherence to medication or other treatment aspects. And also physical health. MI studies showing MI improves physical health with people with severe mental disorders. So there's lots of evidence circling around this. This is something that seems to help not just with addictions, but with the kinds of things that often come with addictions. MI alone is not a replacement for treatment as usual. So it's not as simple as doing an MI session and the co-occurring disorders are gone. The normal procedure is you add motivational interviewing to other evidence-based treatments. And in a way, it's a clinical style for delivering other evidence-based treatments. I'll get around to that. Even relatively brief MI before treatment improves treatment attendance and adherence. And MI-based interventions improve psychiatric symptoms. So there's a very reasonable amount of evidence there. This is not something that only worked with alcohol and drug problems. Fourth edition, most recently, we wanted to simplify it because it's being used now in so many professions outside of psychotherapy that we wanted to try to say, what's the essence of it? If you're a financial counselor, if you're a diabetes educator, you're not a psychotherapist, you're worried about those kinds of things, but what do you actually do that makes a difference? So it's the fourth edition has got smaller, 30% smaller. And we reduced a lot of the jargon, particularly psychotherapy jargon, and completely rewrote the book, which we did every time. And we talked about helping people change and grow, because this is something that mentors do over time. This is something that teachers do over time. This is something that primary care practitioners do over time. So it can be a way of working with people, not just on a discrete change at the moment, but on growth over time. And we wrote it for a much broader audience. Still have a good definition of motivational interviewing, a way of talking to people about change and growth that strengthens their own motivation and commitment. Didn't change the processes. Just added more on how to give information and advice, because it makes a big difference. And more on MI spirit. More emphasis on strengths. And MI is a way of doing what else you do. It's a clinical style for delivering other kinds of treatment. And we added some on genuineness for a reason that I'll tell you. Now, if you know the therapeutic literature in mental health, you know that when you compare different therapies with each other, done by people who are trained in and believe in them, you tend to get similar outcomes, just like we did in Project Match. But therapists get different outcomes. So you compare treatment A with treatment B, they look about the same, but you compare therapist 1 with therapist 2 during treatment A and they look different. Terry Moyers and I got interested in this and published this book, Effective Psychotherapists, going back through 70 years of psychotherapy research, saying, what is it about therapists who get better outcomes? And we found these 8 skills that are related to better outcomes across theoretical orientations. And then I looked at that list and I said, after we finished the book, they look familiar. Accurate empathy has been part of motivational interviewing from the beginning. Positive regard, affirmation has always been part of MI. Genuineness we hadn't talked about. being yourself while you're doing MI. Now we do in the 4th edition. Acceptance of people as they are has been a key element of MI spirit. Having a clear focus and goals and knowing where you're going, and the client knows where you're going, and you agree about that, and you have a plan for getting there and you stick to it. That's an important component of effective therapists. Conveying hope to clients, evoking from clients things that help them to move in the right direction. And then the smallest effect overall was giving information and advice. And I think because it matters so much how you do it. So I've begun to wonder, is this what we've been teaching all this time? Because we didn't really develop a new theory of psychotherapy. MI is not a theory of how people get sick, or what's wrong with people. It's a way of being with people. And it's not meant to be used instead of other evidence-based treatments. It's meant to be combined with them as a way of doing them. So it's interesting to me that in a way from the beginning, that seemed to be what we've been focusing on, how to be helpful as a helper. And it's a way of doing cognitive behavior therapy, a way of delivering healthcare, a way of doing diabetes education, a way of preventive dentistry, interestingly, a way of practicing social work and child protective services and case management, a way of supervising people on probation and parole, a way of coaching athletes to be their best, a way of teaching in the classroom and of educating more generally, and a way of leadership. It's been applied in all of those areas. And it seems to work across theoretical orientations and professions. It gets called non-specific factors sometimes, but that's a mistake because these are specific. You can measure them. You can see how well somebody's doing it. You can learn them. Sometimes they're called common factors, but they're not universal. I mean, high empathy is not common across therapists. It's variable. So what are we doing? What wins a race? Is it the car or is it the driver? What makes a great meal? Is it the chef or the ingredients? What lights up a room? Is it the candle or the flame? I think what we're doing in clinical training and teaching motivational interviewing is helping people be safer drivers, better chefs, brighter flames. Thank you.
Thank you so much, Bill.
Thank you so much, Bill.
I'm going to stop sharing now. There we go. Okay. And I can actually see.
Feel the clapping?
Yes, thank you.
Cool.
So happy for questions. If they were posed in the chat, Lindsay can vet those for me. You can also just kind of put your hand up and speak up and ask a question. So whatever. So you're in charge, Lindsay.
Okay. I have a few questions from the chat. So am I echoing at all? I feel like I'm echoing a little. Is it okay? Okay.
Sounds okay here.
Good, good. Okay. Nancy Wolford asked, I'm wondering if Bill might be able to go more into how he helped the clinicians implement the spirit of MI and explain how it made a difference in their approach to MI versus using MI on the client.
Yeah. Well, besides talking about the spirit of MI, how do you teach it? And 4 things that we do in training is tell, show, try, and learn. So tell is I'm going to talk about it. Show is I'm going to demonstrate it so you can see what it looks like. Try is now you begin to implement. Try this, and you give people more specific tasks to try along the way. So you're kind of building up skills over time. And give people feedback. That's the learn component as well. So combinations of explaining, modeling, practicing, and getting feedback. And MI spirit components like empathy are measurable, and people can get feedback. They can even count their own reflection to question ratio and so forth. It's a skill. These aren't personality characteristics. They're all measurable skills. And so the empathy is a big piece of it. But then there are things like facial expression that can convey lack of genuineness, that your facial expression doesn't match what you're saying. You see this in clients, you also see it in therapists. Or how mobile is the counselor's face? If a counselor imagines what they need to do is to be an impartial, distant, objective observer, will have a kind of immobile face, which is weird. Because normally when someone's talking to you, you're responding facially as well as verbally to what's going on. So not only would you have verbal responses like reflective listening, but your face ought to be in some way reflecting what the person is saying. You should be able to see in the face something of what the client is communicating as well. If the face is immobile, that's weird. That's not the way we interact with each other. So part of genuineness is facial mobility, and that's something that I watch in training therapists as well. Say, relax, let your face move a little bit. Show me how sad looks. Show me how happy looks. Show me how frightened looks. What's going on with your face? Sometimes people keep their face immobile, trying to look professional. But genuineness, being yourself, being a real human being, is one of the things that increases therapeutic effectiveness. So that's a piece of it. The music and the voice, how you say something is so important. You don't see anything wrong with what you did is a pretty good reflection and communicates acceptance. Same words. You don't see anything wrong with what you did. Very different communication. So trainers and supervisors need to attention to those kinds of things too. What is it that you're seeing, and get good at identifying the cues that you're asking the person to make a change in as well. So those matter. Nonverbals matter. Tone of voice definitely matters. It doesn't take much tone of voice change to turn something into a confrontation. You don't see anything wrong with what you did. Same words, very different communication.
Well, thank you. So Cordelia had a few great questions. Her first one is MI truly transdiagnostic approach for motivation and inviting change, or are there some presentations or experiences like diagnoses that are contraindicated?
We haven't found one yet. I mean, I have to leave the door open that there may be diagnostic conditions where this at least won't work, or even potentially get in the way of recovery. But we've had lots of predictions of diagnoses where this will never work. Psychosis, for example, early on. Well, Carl Rogers was doing client-centered therapy at Mendota State Hospital with schizophrenic patients before Thorazine. I mean, you can do it, and there's a pretty good literature at this point on at least things like medication adherence and retention and treatment with people with severe mental disorders. In Project Match, we said MI will be less effective with people with antisocial personality characteristics because those people don't form relationships. Psychopaths don't form relationships. And this is a relational thing. Wrong. It was simply unrelated to efficacy. What about cognitive problems? What about people with closed head injuries? Well, Chuck Bombardier has been studying this for a couple of decades now, and With closed head injury, you can get increased impulsivity and some kinds of difficulties like that. And yet he finds this relational aspect is very helpful in the way you practice with people, learning the skills they need to learn to recover from an injury like that. So a more common question lately is autism. Don't have a literature there yet. So don't know is the question. And when someone asks me, well, can you use motivational interviewing with diagnosis X? If there's not a literature, my usual advice is, well, try it. You know, just see what your experience is with it. You know. But so far there are not diagnostic contraindications to the use of a person-centered approach more generally, and motivational interviewing in particular. And it is, by the way, a person-centered approach. People get it mixed up with behavior therapy, but it's firmly rooted in the work of Carl Rogers and interpersonal dynamics of therapeutic relationship.
In branching off of this, Cordelia wanted to clarify, is MI recommended for folks with disordered eating or depression, kind of, et cetera, but without substance use?
It doesn't seem to have a big direct effect by itself on eating disorders. So it's not a standalone treatment for eating disorders. But as a clinical style, again, it seems to be helpful with because just having someone with anorexia, for example, trust you and be able to work with you is really important, as it is with anxiety disorders. I mean, if you don't trust your therapist, it's going to be tough to make very much progress. Person-centered approaches are very good at building therapeutic trust and doing so relatively rapidly. So this is not a solution for eating disorders, but it is a way in which you can work with people with eating disorders and apply other tools, evidence-based tools that are helpful.
And Cordelia, lots of good questions. She said that I'm in the invitation to change / craft world. What are your thoughts on what it might take for family members to learn MI? And then she kind of continues, what level of specificity for spirit and technique might be necessary and sufficient for when teaching this to lay folk for them to help their loved one towards recovery or reduction of use and increased connection?
Yeah. Relatively new area, by the way, teaching these skills to parents. Although Thomas Gordon was doing this in 1970, teaching empathic listening, at least, as a skill in what he called parent effectiveness training. So I'm pretty confident that the empathic listening skills are useful to teach to clients and to couples and to parents and so forth. Where it can get tricky is when you get into the evocation skills and you have an investment. It deeply matters to you which decision the person makes and so forth. I can sit with a client and say, so cocaine is really helpful to you. It's something that you find you like it a lot. I have trouble saying that to my son, because I have a personal investment relationship with him, and so that's one where you can get into manipulation, and people see it in a minute. As soon as you start trying to use these techniques to trick people into changing, they pick it up instantly. So I think the relational skills of MI, sure, with parents. The technical skills of listening for and evoking change talk, maybe. We don't know yet. And then cautions about crossing boundaries with these skills. So it's not a simple answer there, but I think at least some aspects of MI can be very useful. And I certainly taught empathic listening to couples and to families.
A couple more questions are popping up in the chat.
Good.
Ashley Mayo, sorry if I said that wrong. How would you use MI on the teenage brain as opposed to the adult brain? Is there a difference? She kind of goes on, I haven't read it through yet, so probation rules have to be followed regardless, and probation officers have to uphold them even if we emphasize with kids and come to them on their level. So we have to make them follow rules, but also want them to change even when they do not believe their behavior and the way of thinking are a problem. Does MI change based on the age of the person you're working with? It's kind of a couple of things going on there.
Lots of questions in there. Yeah.
Yeah.
I wouldn't use it on any brain. But it was a question early of, yeah, okay, this is working pretty well with adult people with alcohol drug problems. What about teenagers? We don't know, because teenagers can defeat almost anything. So we did a clinical trial with kids being brought into almost always against their will addiction treatment, usually by the parents or the courts, or being pushed through the door by somebody who didn't want to be there, using alcohol and drugs. And we got the biggest effect we had ever seen of motivational interviewing on retention, on behavior change, larger than the effects we'd seen with adults. Well, again, that's interesting. What's that about? Well, often adults don't listen to kids. Don't try to understand their perspective on things and reflect it back and join with them as we do with fellow adults, you know. And when you do that, when you follow the spirit of motivational interviewing, which is companionship and respecting autonomy and so forth, with teenagers, have almost a contrast effect. It's so unlike what most people are doing with teenagers. That it can have a bigger effect. And I think it's similar to what happens, by the way, with minority populations. White people are accustomed to being treated with respect and sort of expect it. But that's not the normative experience of people who are Black and Hispanic and Chinese and so forth. And when someone meets them in a healthcare setting with this spirit and way of being, it's very different from what the normal experience that they've had. And I think that may be one reason why we get bigger effects with minority populations than we do with so-called majority populations. So my experience with kids is that this is even more effective with kids than with adults. You get even bigger effects over time, or at least it's at least as effective as it is with adults. Now, what else was in there? There's special challenges of probation, because you have things you must do, things you must follow. And you have to be honest about that and, let people know what the limits are for you. And at the same time, you can be empathic and honor autonomy and accepting in that kind of context and working with people. And it again seems to be helpful in settings where we're used to doing authoritarian things, correctional facilities and programs. This is a big contrast, a different way of doing things. And is it doable there? Yes. But you have two roles, to advocate for your client and also to protect society and respond to the requirements of the court. And both of those are requirements for the professional.
And this is Jim asked a question. I think that I'll dig a little deeper into this. He asked, any advice for those from a corrections or probation background on how to balance the spirit of MI with the reality of being the person imposing a consequence when a person is not ready to make a change?
Well, probation officers who use this approach are some of the best people to talk about this, because they know how to do this. But you might say, if I get a positive UA from you, this is going to happen. I don't have a choice about it. And I have to report that. Or working with parents in a child protection situation, If we find evidence that your child is being physically harmed, I must report that. So I want you to know that, I do not want you to go to prison. I want you to be free. I want you to have a good life. That's what I'm here for. That's why I do this work. I want to be your advocate. I want to help you with that. And there are limits within which I work. And so there are certain things that I must respond to, even though part of me doesn't want to. That's what I have to do. So any questions about that? We do that in informed consent procedures also. If you report to me the abuse of children, I'm required to report that. So pretty routine for therapists to do that. So it's like that same balance, and it can work. You can do it, and it's a very different oppositional mindset than cat and mouse. Cat and mouse is my job as a probation officer is to catch you doing what you're not supposed to be doing. That's an unhappy role for both people. So yes, you can practice and manifest the spirit of MI within a situation where you are required to impose consequences. And you can let people know, you're not happy about this. This is not what you would choose for the person. But it's part of my role too.
Seems important to do that up front.
Up front, absolutely. To have a conversation about it up front.
We've reached the end of the chat questions, so I wonder if folks have questions or items for discussion while we have a little time left.
There's a hand raised from Adam.
That was quick,
Go
Adam.
ahead.
Go for it.
Yes,
Go
my
ahead,
question is dealing with if I have to utilize a interpreter in my location, how does what does that look like?
I have done that. And I can tell you the interpreter really needs to understand MI. For example, I was working in Japan with a client and I reflected something the client said, and the interpreter then said to me, well, she already said that. So it's important for the interpreter to have at least some basic understanding of what you're doing. And it's tricky because there's always a step in between every response, but nonetheless feasible. Then you can hear change talk in a translation. You can do reflection and affirmation by translation. And it's important for the interpreter to understand what you're doing and why you're doing it. Then there's the cultural context as well. When you're affirming, for example, that comes into a cultural context with which you may not be familiar, and it may have an overtone to it. And the interpreter might try to correct for that, or might tell you privately about that to start with before doing the interpretation. So it's always trickier to work through an interpreter. And actually, the best person to do MI is the interpreter, if they know how. Yeah.
Thanks.
What other questions? I have a chat. Any advice for individuals to let go of control and their own agendas and biases? Helping professionals often have the best intentions, are not even aware of the implicit control that you're putting forth.
Oh, yes. Well, and if the things that bring us into helping professions can get in the way also, you want to help. And in a way, what your gut tells you to do when you see somebody going down a path that doesn't go to a good place is to try to get out in front of them and say, no, go back. Don't you see this is a much better way over here, which is advocating for change and tends to get sustained talk in response. So we do, with the best of intentions, with a heart of wanting to help, do things that can have an opposite effect. The normal response to unwanted advice is either to do nothing or to do the opposite. You know? And yet giving advice is the thing that your gut kind of wants to do with your teenager and with your clients and so on. And the results are predictable, you know, where it's going to go. So, I mean, understanding this way of being with people involves some restraint. It's kind of holding back the things that in a way your gut is screaming for you to do. And yet you know where that goes if you go down that path. You know the result of it. You can say in the chart, I told them they have to do this and what the consequence is and so forth. So you've covered yourself in terms of liability. But responding to people in that way pushes them in the opposite direction. So we were ironically in addiction treatment doing the very thing that causes people to continue using drugs, to continue arguing for their freedom and their the goodness of drugs and so on. Didn't know we were doing that. We were wanting to be helpful. We just had a belief system that I have to use my expertise. And how to use your expertise is in a way at the heart of motivational interviewing. Because expertise is one up in power, and most people don't respond well to having someone in greater power tell them what to do. So you need to join with people and communicate partnership and communicate respect for autonomy. And then people can listen to you.
This is a really good question. Faith asks, are there any situations where you would not advocate for change? For example, someone has a terminal illness and they want to die.
Well, sure. First of all, I don't get to decide what people are going to do. So, but sure. I mean, in a way, advocating for change is something that I seldom do. I will have conversation with people about change and may encourage them, like with in addiction treatment. If you're completely neutral about drug use, you're not doing your job. You know, if people come in and talk to you about what they do and you have no interest in causing them to change that, what are you doing there? You know, but to do it in a directive, prescriptive, authoritarian way actually pushes people to continue. You know? So understanding these dynamics is really important, and how to be helpful to people and how to use your expertise in consort with and collaboration with the person's own expertise and autonomy about themselves. That's some of the balance.
Kind of taps into when is neutrality important.
But there are certainly situations in which I have no business advising people what to do. The example I used in the very first article about MI was people coming in trying to decide whether to have children. And it's not my job, either directly or indirectly, to nudge people in the direction of having children or not having children, by the way. Either way, that's one that I need to be neutral on. And you behave differently than you do with classic motivational interviewing when you're practicing neutrality, because you're equally interested in the person's sustained talk and change talk. You're equally interested in their motivations for and against change. And you're careful not to side, even inadvertently, with one direction, because you can inadvertently steer people in a particular direction without either one of you realizing it. So the discipline that we've learned from the psycholinguistics of change is very helpful when I want to be neutral. And I practice differently than when I'm trying to encourage someone in the direction of change, typically because that's what they've asked me to do.
Yeah. Okay, we have hit the mark on the dot. Thank you so much, Bill. This has been amazing. I'm putting in the
Thank
chat different surveys that we would really appreciate your filling out. The data and feedback we get from you is very important to the work that we do. But big, huge thank you to you, Bill. I'm so glad you could be here to kick off this series. You're always an inspiration, and it's just so fun to be able to hang out with you. And thank you everyone for being here. Please feel free to email us. Let us know if you have questions or just want to share anything. So I love all the little hands clapping everywhere. It makes me deeply happy.
everybody.
All right. So long, everyone. Thank you so much. Take care.